But looking globally, you have someone who has not used contraceptives and their risk ratio is 1. And if you look at everyone who takes any form of a contraceptive, their risk ratio is 1.2. So that means they're at about a 20% increased risk of using an antidepressant. Looking at, again, the sort of state of information in contraceptive literature, we have this kind of gem that we came across of the risks of severe depression, anxiety, and suicidal ideation with hormonal conception. And this is a company report put forth by Bayer. So we'll just go ahead and scroll down through this and see if we can pick out some gems from this report.
3.21. It's good data from 3.21.
So there's the heading and a couple dozen pages. And well, I guess there's nothing concerning about mental health that was uncovered by Bayer in their company report.
It's all redacted. It looks like a government document.
It really does. But we're just using this as an example to sort of speak to what is, I guess, not openly discussed or not even openly posted online about different contraceptives and their effects on mental health. But as mental health comes more to the forefront, you do have these, sort of health sources, or not health sources necessarily, but influencers putting out information about contraception and mental health sequelae. So we might as well dive into it. Sometimes these people are doing a bit of fear mongering because clearly not everyone who takes a contraceptive develops depression, but there are reasons why some contraceptives may be better than others or worse than others for someone who, let's say, has a predisposition, maybe family history or something genetically that predisposes them towards depression.
Reading a study like this, you always look at how the study is designed. So, they have 2 different groups of people, no use of hormonal contraception, and then all hormonal contraception, and then groups, for example, specifically the levonorgestrel group with high estrogen, medium estrogen, no estrogen, and an IUD. One of our first questions was, well, why is the first diagnosis of depression so much lower than the first use of antidepressant? And reading the fine print, it looked like they define that as diagnosis of depression at admission, like psychiatric admission. So quite severe.
Yeah, it's some sort of, psychiatric facility. So my question was, wouldn't the diagnosis of depression typically precede the prescribing of an antidepressant? So we dug in a little bit deeper and found out that that's where that sort of disparity in the numbers were. But looking globally, you have someone who has not used contraceptives and their risk ratio is 1. And if you look at everyone who takes any form of a contraceptive and their risk for first use of an antidepressant, their risk ratio is 1.2. So that means they're at about a 20% increased risk of using an antidepressant.
The 95% confidence interval for that was 1.22 to 1.25. So that's a pretty narrow range. That's relatively good assurance that yes, it's between that value. So that's statistically significant, and we certainly think it's clinically significant as well.
Yeah, I think this does play out in the real world because there's a really significant number of person years here. Looking at, I think it's north of 3 million person years in this study. And one of the interesting things to me was looking at when you have a progestin combined with an estrogen versus when you have just a progestin. The progestin-only contraceptives seem to have a pretty profound increased risk, in my mind, for causing depression. They have about a 30% increased risk versus something like a, let's say 20% with just global contraceptives. And then if you go an even more granular at another level, if you're using a progestin-only contraceptive that also antagonizes the androgen receptor, those have an even more significant increased risk for depression, meaning the first use of antidepressants in this column. So that one is up to about a risk ratio of 1.4. So I think that's really interesting. And it almost seems like having androgen signaling and estrogen signaling might be important for people's mental health.
Yeah. And there's, of course, many causatory reasons for this. Some of the main ones is estrogen is involved in the conversion of tryptophan to serotonin and serotonergic signaling. So if you're not estrogen dominant, then it's probably a particularly poor choice. But if you are estrogen dominant, maybe it still is a decent choice. And then you already mentioned the predisposition towards anxiety and depression. If there's an individual who is already somewhat dysregulated, then it might not be a great choice. The anti-androgen contraceptives, you think, androgens are close cousins of dopamine. Androgens can help effort feel good. Dopamine can kind of be the motivation hormone as well. They did not delineate between why the first use of antidepressants was. So it could have been depression and it could have been anxiety. Serotonin is very important in anxiety disorders, and SSRIs are actually first line for anxiety disorders. So it could have been both of these conditions.
Yeah, that's another really important detail. What about the levonorgestrel IUDs? This is really interesting that this is associated with an increased risk of depression. If I was looking at this and it was only that, say a singular study that said levonorgestrel IUD associated with depression, well, then I could think, well, maybe it's just that, some characteristic about this group that is seeking out contraception and willing to have this somewhat invasive procedure to place a contraceptive device. Maybe they're more predisposed to depression. Maybe they don't feel that mentally they're in a good place to conceive at this time. But this is in the context of being weighted to all other antidepressant or other conception methods. Yeah. And they still had an increased risk of being prescribed an antidepressant. But I see a lot of messaging out there that says that IUDs, all of which use the hormone progestin, actually they use the hormone levonorgestrel at this time, the 4 that are out there, that they do not go systemic. I see people talking about this, that they only work in the uterus. Then I see people that are being a little bit more responsible in their messaging. They say that they work mostly in the uterus,
correct,
which I think is more accurate. So what are some of those changes that we see outside of the uterus with levonorgestrel, besides the risk for use of antidepressants here?
Certainly higher copper levels, even though it is not a copper-containing IUD. Paragard, of course, increases copper levels as well. And then you see a lot of changes in the ovary, probably partly because the ovary is pretty close to the uterus. But it will change, and it kind of depends on the scenario, but about 20% of people, at least that's the number last I remember, do not ovulate while they have a levonorgestrel. And that also might change as the hormone level wears out toward the end of the IUD. But about 20% of people do not ovulate. In addition to that, there is small amounts that circulate systemically, and those small amounts very likely do bind to the pituitary and the hypothalamus and are potentially neurologically active. So there's quite a few effects.
Yeah, and one of the things with levonorgestrel in particular and synthetic progestins really is that they don't always play nicely with your endogenous progesterone receptors. So when you look at women who have had a IUD in place versus women who never used hormonal contraception, there are differences that are visible on contrast MRIs in the breast tissue. So there's probably a non-zero increase in risk of breast cancer, even with a progestin-based IUD. I would speculate. I don't have that data to pull from, but I would speculate based on some of this data that is available out there.
Yep. Anytime you talk about changes in the breast, and actually in multiple other systems of the body as well, then thinking about the push and the pull or the tug of war between androgens and estrogens is important. In the liver, this is very important with SHBG as well. But in the breast tissue, having adequate androgenic signaling can be important to kind of like impair the growth, whether it is, a normal breast tissue cell, like glandular breast tissue, or whether it is a neoplastic or pre-neoplastic cell.